Welcome everyone to our monthly Dunlevie seminars. Just a few center updates. Really happy and proud to present our seed grant awardees for spring 2024. Dr. Stephanie Leonard for her research project optimizing treatment of chronic hypertension in pregnancy using a national distributed data network, and Dr. Virginia Nguyen on impact of absence or presence of corpus luteum in early pregnancy on maternal immune profiles. So congratulations, Dr. Leonard and Dr. Nguyen. Before I hand things off to Dr. Igbinosa, just to give a heads up about our June, about our next seminar. We're going to take a couple of months pause in July and August, and then get back together in September with Dr. Ann Borders, who is a clinical associate professor at the Pritzker School of Medicine and University of Chicago, and the executive director and obstetric lead for the Illinois Perinatal Quality Collaborative. She is a maternal fetal medicine specialist and a wonderful person and speaker. And so with that, I will ask Dr. Igbinosa to present our speaker for June.
All right. Hello, good afternoon, everyone. I have the pleasure of introducing Dr. Michelle Williams. Dr. Carmichael and I attended an epi seminar and were very blown away by her talk and said, hey, you need to come talk to this group. So Dr. Williams is a renowned epidemiologist, an award-winning educator, and widely recognized academic leader. She recently stepped down as the Dean of Faculty at the Harvard T.H. Chan School of Public Health after 7 years, and is currently spending a sabbatical year as a visiting professor at Stanford University with us. Following her sabbatical, she will return to the Harvard Chan School as a Joan and Julius Jacobson Professor of Epidemiology and Public Health. Prior to becoming dean, she was the professor and chair of the Department of Epi at Harvard Chan School and program leader of the Population Health and Health Disparities Research Programs at Harvard's Clinical and Translational Science Center. She's previously also had a distinguished career at the University of Washington School of Public Health. Her research places special emphasis in the areas of reproductive, perinatal, pediatric, and molecular epidemiology. Dr. Williams has published more than 530 scientific articles and was elected to the National Academy of Medicine in 2016. In 2020, she was awarded the Ellis Island Medal of Honor and recognized by PR Week as one of the top 50 health influencers of the year. Dr. Williams has an undergraduate degree in biology and genetics from Princeton, a master's in civil engineering from Tufts Universities, and master's and doctoral degrees from the Harvard Chan School. And with that, I welcome Dr. Williams.
Thank you. Thank you. I'm going to share my screen. Hopefully this works. Does that look right?
Perfect.
Awesome. Thank you for that generous invitation, Ibgu. I'm delighted to have an opportunity to present and to sort of re-enter the space of being a faculty member again. For the last 7-8 years, I've put my own research on the sideline to serve as dean, and I'm really using this sabbatical period to reconnect with some of the work that I had put on the side. And today, what I'd like to do is talk with you a little bit about 2 particular projects that I'm looking to reinvigorate. Just as a background, the first 20 years of my career, I was at the University of Washington, where I had the privilege to be embedded in a large maternal fetal medicine practice at Swedish Medical Center. And some of you might know David Luthi and David Nyberg, who really ran an incredibly high volume MFM program in a community hospital at Swedish Medical Center. And they collectively invested quite a lot in developing a kind of clinical epidemiology, population epidemiology program that I was a part of. Most of my career I spent using epi methods to study preeclampsia, gestational diabetes, preterm birth, and placental abruption. And for today's conversation, I'll focus on placental abruption. But my work has always been driven by wanting to understand the three fundamental compartments that are involved in pregnancy, reproduction in pregnancy, and that's the maternal compartment, the placental, and the fetal, and how these different biological systems align themselves for the process of pregnancy has always been a fascination for me. So this audience knows pretty much that placental abruption, is defined as the premature separation of an implanted placenta. Early on, people used the word normally implanted placenta, but I think over the years, the accumulation of evidence from longitudinal studies clearly indicate that placental abruption usually are not necessarily coming after a normal implantation. A lot of early studies show that there's some placental disruption that happens well before 20 weeks that characterizes risk for future abruption. And no matter where you are in the world, the rough prevalence at birth for a placental abruption is about 1%. And we know that 50% of abruptions occur before the onset of labor, and 10 to 15% are not diagnosed until the second stage of labor. And despite the relatively low prevalence of placental abruption, it is a significant cause of maternal and perinatal mortality and morbidity worldwide. Overall, fetal mortality rates is about 20 to 40% due to prenatal hypoxemia. And we know that maternal complications include shock, coagulopathies, disseminated vascular coagulation in short term. And I'm going to emphasize the epidemiologic evidence that shows placental abruption is associated with cardiovascular disease in the long term. This is just a snapshot of how we, my group and I and others, have conceptualized abruption as a harbinger of maternal cardiometabolic disorders and cardiovascular mortality later in life. One early study showed that a history of placental abruption was associated with a 4.3-fold increased risk of cardiovascular mortality decades after the complicated pregnancy. And another study showed that all-cause mortality was increased twofold within 15 years of follow-up after an abruption-related pregnancy. And in in 2013, colleagues actually looked at biomarkers of women who had had a history of placental abruption, and 6 to 9 months postpartum, these pregnancies were characterized by having persistent chronic systemic inflammation, dyslipidemia, and hyperglycemia compared to women who had pregnancies and were followed for the same time but did not have abruption. A couple of years ago, I had the privilege of playing around with some of our colleagues in Denmark who have, as you know, a beautiful data ecosystem that allows us to look longitudinally at women's health. And we put together a cohort that included 13 million plus person years of women with at least one delivery. And among those, that population, 11,000, almost 12,000 of those women had pregnancies complicated by placental abruption. It's the largest and longest follow-up that I know of to date of cases with abruption. And in that analysis, we were able to confirm earlier observations of an elevated risk of cardiovascular mortality, almost 3-fold increased risk associated with an abruption history, and cardiovascular morbidity as well increased in this population. Now, I interpret the basic epidemiology that's emerged over the years as thinking about placental abruption as an ischemic placental disorder. And I think the accumulation of evidence over time tells us that there are actually two different etiologic pathways that lead to abruption. One is a chronic pathway of poor placentation over time. And another one is a more acute pathway where perhaps the placenta is normally implanted, but an acute event triggers that premature separation. On this slide, what I've tried to do is summarize the processes that are considered chronic and important in the pathophysiology of abruption. On the left side of the slide, the processes are identified here. And then on the right side, I try to point to signs and evidence in the published literature that reinforces these processes. So for example, impaired placentation, impaired trophoblast invasion in particular, and evidence of maternal fetal hemorrhage early in pregnancy all indicated across different studies that showed by Doppler or uterine artery notching Doppler, or even by ultrasound, altered Doppler results, or even on ultrasound seeing placental sonulucencies. This is a picture of one of a patient that David Nyberg had that subsequently went on to go and deliver, had an abruption, complicated pregnancy. And you can see that, Swiss cheese type characteristic of the placenta well before the abruption occurred. A chronic impaired placental perfusion and oxidative stress is another pathway, and that's been evidenced by a series of biomarker studies done early in pregnancy, where growth factors and placental mitochondrial disruption or dysfunction have been identified. And then, of course, platelet activation and endothelial activation and dysfunction as evidenced by early pregnancy changes in biomarkers reflecting that pathway. On the more acute side, the processes that lead to placental abruption are listed here: thrombosis, shear stress, infection, inflammation, and acute vasoconstriction. And on the shear stress side, we know that a sudden decompression, the delivery of a first twin, for example, can result in an abruption prior to the delivery of the second. We also know from a lot of population-based studies that a fall or a blow to the abdomen in car accidents, for example, can trigger placental abruptions. And elevated pro-inflammatory cytokines, macrophage, and have been infections in these compartments are evidence of the inflammatory and infectious roles that are played. So if we think about placental abruption and we conceptualize it as an ischemic disorder, then I would argue that the brief episodes of intense physical exertion, which are associated with a heightened risk of ischemic cerebrovascular and cardiovascular disorders, might also be a risk factor for placental abruption. In other words, similar to what we've seen where extreme exertion triggers heart attacks or strokes, might we identify a similar pattern for an ischemic placental disorder, i.e. placental abruption? So with that in mind, I and my colleagues several years ago sought to acquire research funding to answer the following question, to address the hypothesis that the risk of abruption is higher within an hour of intense or moderate physical exertion compared to other times, and that trigger of intense physical exertion or moderate exertion will trigger abruption, and it varies by the intensity of the exertion or whether the woman has habitual physical activity or she's habitually sedentary. And what does that exertion, acute exertion, look like in the presence of cardiovascular compromise like preeclampsia or eclampsia? So as an epidemiologist, there are many tools in the toolkit to answer lots of different clinical questions. And the case crossover design, which I'll talk a little bit about, is a design that allows you to ask a specific question. And that is, was the event, let's say abruption or heart attack, triggered by something unusual that happened just before that event? In other words, instead of the classical questions that we ask in clinical epi, such as, why are nulliparous more likely to develop preeclampsia? Why are high multigravidas more likely to develop abruption? Why are twin pregnancies more likely to lead to complications? Those are why me questions. What the case crossover study design does is it gives you an opportunity to ask, why now? Why did this event happen at the time that it did? So the case crossover study design allows to answer that question, and briefly, it is a self-match case crossover design. It compares the exposure preceding the event with the expected frequency of exposure based on the patient's usual frequency. So in the case of activity, it would compare the acute onset of extreme activity compared to the patient's usual frequency of activity, let's say over the past week. This is an example of how the study design is used in the context of studying non-fatal myocardial infarction. This was a study done by Anna Balin and colleagues at Harvard back in 2007. And their goal was to evaluate whether or not heavy physical exertion, sexual activity, acute respiratory infection, and gastroenteritis, whether these triggered an MI, a non-fatal MI. And what's summarized on these slides is that the investigators identified that the risk of myocardial infarction an hour after physical exertion was elevated almost fivefold, 4.9. And just looking at the table, another factor, they found that within an hour of sexual activity, the risk for an MI increased 5.5-fold. On the bottom part of this slide, what's really interesting is the investigators get to ask the question about how the triggering effect of heavy exertion influences MI based on an individual's routine, habitual physical activity status. Meaning the more sedentary the person, the more likely they are to have an extreme acute event given exertion. And what you can see in the bottom of this slide, and I don't know if my pointer works, but the most sedentary population here have an extraordinarily high acute risk of MI after within an hour of physical exertion, almost a 27.5-fold increased risk. The more active the person, the more fit the person, that heavy exertion does not lead to the same acute risk for MI. So I hope that gives you a little bit of a background of how the study design is used in the context of studying an acute event like a myocardial infarction. And I was inspired to deploy this particular study design in the context of abruption because I think it fits the criteria for where a study design like this would be useful. The study design is actually applied best if the exposure is intermittent, if the effect is immediate and transient, and if the outcome is abrupt. And you can see, given my longstanding fascination and curiosity about the etiology of abruption, I couldn't pick a better perinatal outcome than placental abruption to play with this study design. So I needed large numbers of incident abruptions. And I'd had a long-term relationship in teaching and mentoring and doing research in Peru. And across 7 different Peruvian hospitals, we were able to accumulate something on the order of about 30,000 deliveries a year across these 7 hospitals. And that allowed me to effectively, cost-effectively, and pragmatically recruit and study up to 663 women with placental abruption during the period of 2013 and 2015. Studies were done in Lima. These hospitals were all based in Lima. And because of the nature of this kind of analysis, we excluded women with multifetal pregnancies and only included women who were residents in Lima, not transferred out from other areas. Just briefly, the interviews were conducted at the time of delivery, and we used the Borg visual analog scale to get women to help us help characterize the level of exertion that they experienced within an hour of a placental abruption. And essentially, we describe and use the cut points that you can see here for heavy, moderate, and light exertion. And then because this was the first time we were doing a study like this in a pregnancy cohort, we didn't know precisely what best window of exposure to work with. So we hedged our bet, and we made sure that we allowed for characterizing exposure to heavy exertion at the time of onset that the woman could report, at a half hour before the onset, and an hour before. And after a tiny pilot study that was done, we thought the window of exposure relevant to the onset of abruption would be within 1 hour of the abruption. And we asked the question for exertion, and then we asked for heavy exertion and moderate exertion specifically. I think many of you know how difficult it is sometimes in large field studies to have a uniform definition of complex perinatal outcomes, placental abruption being no different. So across these different hospitals and across an army of different recruiters and clinical specialists who referred cases to us, we used the following criteria, where placental abruption was defined if one of the following conditions were met: antepartum hemorrhage after 20 weeks of gestation, where previa and other forms of causes of bleeding were excluded; uterine pain or tenderness, localized or diffuse; fetal death or distress; and retroplacental blood clots. And then we also extracted medical records where we looked at clinical and pathology reports, as well as ultrasounds by a single study pathologist who adjudicated the case records with a project coordinator. And the statistical analysis, I won't dwell on this, but is actually pretty straightforward for a complex study design. It's calculating the incident rate ratio and 95% confidence interval using the Mantel-Hansel procedure. And then our test for heterogeneity was using the Wald chi-square test. On this slide, I just give you a little bit of an overview of the characteristics of the women included in the study. Maternal age was close to 29 years. 22% of the population had a concurrent history of preeclampsia or eclampsia. 15% had premature rupture of the membrane. The gestational age, average gestational age at delivery was 34.6 weeks, and only 4% of women had a prior history of abruption. So results. What we saw at the end of all of the data collection was that 5% of the women who reported engaging in moderate or physical activity in the hour before pregnancy. So 5%, or 34 of the 600 plus women had engaged in physical, moderate physical or heavy physical exertion in the hour before pregnancy. And that translated to a statistically significant increased risk of placental abruption within that hour of exertion, a 7.8-fold increased risk of acute onset abruption within an hour of that level of exertion. And because we were concerned that there might be other time-varying factors that would contribute to the risk, we conducted a series of sensitivity analyses that excluded women who had other potential triggers, such as having engaged in sexual intercourse within that hour, or smoked or used illicit drugs. And once we excluded those potential triggers, the strong association remained for moderate and heavy physical exertion. On this slide, what I try to do is show the dose response. So what I reported earlier was just any moderate or physical exertion in the hour before the abruption. Here on this slide, we're looking separately at heavy exertion and the separate contribution of moderate exertion. Just a little orientation for this photo. The bar represents, the top of the bar represents where the relative risk would be. The confidence interval is reflected by this band. And this group would be the women who reported a heavy exertion during the hour before the abruption, and this would be the moderate group. And as you can see, there is a dose-response relationship, if you will, where the heavier the exertion, the higher the acute risk of placental abruption. And all of these associations were significant, statistically significant. Now here, we wanted to see if the triggering effect of exertion differed according to the level of regular activity or fitness of the woman. And so we characterized the population as to women who were engaged in physical activity less than 3 hours, three times per week, versus those who were engaged in physical activity more than 3 times a week, presumably the more fit population. And as you can see, among the more fit, the acute physical exertion actually still resulted in an increased risk of 3-fold. And these are the 95% confidence interval of 1.6 to 5.9. And in the more sedentary group, just as we saw in the study from Costa Rica with individuals with non-fatal MI, the less fit group, the less habitually active group, had a higher risk of the acute event, abruption, in relation to acute heavy physical exertion. And here we're showing women who had a comorbid preeclampsia, eclampsia in the pregnancy. So more vulnerability because of their comorbid condition, and those who did not have the pregnancy comorbid preeclampsia and eclampsia. And again, the women who were more clinically vulnerable, that heavy exertion within that hour of the event was associated with 13.6-fold increased risk of abruption, whereas the women who had been normotensive throughout the pregnancy had only a 6.7-fold, documenting essentially that the comorbid condition combined with the physical exertion conferred an acute increased risk for abruption. So for this exercise, what we were able to show and hopefully encourage others to look at was to see that episodes of moderate to heavy physical exertion are associated with an immediate high risk of placental abruption. and that the stronger association, there's a stronger association for heavy exertion compared to the moderate exertion. We also found that the associations were stronger among patients who had a lower mean weekly frequency of habitual exercise, an indicator of fitness. And also it was stronger for women with comorbid preeclampsia, eclampsia, or hypertensive disorders. Having had an opportunity to use this study design, there are a couple of strengths and limitations I wanted to reflect on. First is that studies like this require a very large sample size, and we were able to do that by strategically partnering with our colleagues across 7 institutions in Peru. The self-matched design helps us control some, but not all, potential confounding factors. And also, having done this study in Peru, we were able to evaluate abruption risks in a relatively understudied population. There are limitations, though, that plague the study design, and that biggest concern is the potential for recall bias, where the study is reliant on self-reported activity or the self-reporting of triggers prior to the acute event. And then another limitation specific to this study is we did not quantify or characterize a specific exertion activity. And for I think improving and making this more translational, we would need to have a better characteristic of the type of activity that led to the heavy exertion and risk. What I'd like to do going forward is explore the efficacy, because we saw such a strong attenuating effect of exertion in women who were more fit, is to explore the efficacy of really promoting preconception and early pregnancy physical activity that supports a higher level of fitness. The other thing we'd love to do in the future is to explore other factors that might be involved in acute risk for placental abruption. And I'll just quickly show you another factor that we've studied. And to overcome this issue of recall bias, one of the things that we could do is, especially for looking at something like physical activity, is begin to use wearables to collect objective, unmeasured, unbiased measures of putative triggers. This is just a quick slide because I want to get to one of the genomic studies that we've done. I wanted to just show you that we've also looked at acute activation of the sympathetic nervous system, namely through outbursts of anger. And here, this is just a quick synopsis of the study that we published in 2019, where we identified that women who that the rate ratio of placental abruption within 2 hours following an episode of anger was associated with a 3-fold increased risk. And then we looked to see if that risk varied by low or high education, and women with lower educational attainment had a higher risk. We looked to see if the risk varied by a history of depression or preeclampsia, and you can see in the table here what those risks were, dependent on the presence or absence of these other risk factors for abruption. Okay, I'm going to switch gears and talk a little bit about a series of studies that, again, I'd like to pursue more deeply. And this is something Virginia and I talked briefly about yesterday when we had a brief one-on-one. And that is, how can we, in epidemiologic studies, pursue an analysis where we account for multiple genotypes at the maternal-fetal interface with the pathophysiology of placental abruption. And what I'll just walk you through quickly, because I'd love for us to have time for discussion, is the rationale and then the hypothesis that we pursued in this particular series of studies. So our rationale here, we'd shown several years ago that maternal genetic variations in the mitochondrial biogenesis and the oxidative phosphorylation pathways are associated with placental abruption risk. We've done this doing GWAS and then calculating genetic risk scores that evaluated placental abruption risk in relation to the density and intensity of genomic variants found in these pathways. And we also know that placental abruption is a complex multifactorial disorder that is characterized by this premature separation of the placenta. And so we were very interested in what are the how can we evaluate genetic risks where the ischemia is happening at that maternal interface, looking at both maternal and fetal genetic interactions. So our hypothesis was that the maternal-fetal genetic interactions and imprinting effects, where the risk of abruption might be conferred depending on the parent of origin of the variants, we argued that those interactions and the imprinting effects may explain some of the missing heritability in complex disorders like we've seen in placental abruption. So our goal was to use the largest assembled maternal infant dyad of abruption cases and controls. And this, over the years, we had accumulated 503 placental abruption cases and over 1,000 controls where we had GWAS data for 503 cases and over 1,000 controls for both mother and the fetus, the infant. And so then we wanted to investigate these maternal-fetal genomic interactions within the mitochondrial biogenesis and oxidative phosphorylation pathways, look specifically in that pathway for evidence of interaction and imprinting effects. And just briefly, what we found is we identified two novel maternal-fetal mitochondrial biogenesis SNPs interactions and imprinting effects. For example, we found that a maternal-fetal interaction was observed for SNPs in the calcium calmodulin-dependent protein kinase, or CAMK2B. And we also found the interaction, maternal-fetal interaction for peroxisome proliferator activated receptor gamma, or PPARG. So these two SNPs were in the same genes that we had identified previously in a subset of the population that we reported on here. For PPARG, we reasoned the following observations to try to understand how interaction could be important here. For PPARG, we know that it is associated with enhanced mitochondrial biogenesis in other studies. And we also know from earlier studies that it is highly expressed in the placenta, where at high levels inhibit trophoblast invasion through oxidative LDL in cytotrophoblasts of cells involved in the invasion of the uterus. And then finally, PPARG has been associated with the development of preeclampsia, which we know is a well-established risk factor for placental abruption. For CAMK2B, this is CAMK2B is a member of a family of genes implicated in contraction-induced regulation of the calcium handling in skeletal muscle and activation of mitochondrial biogenesis. It also is expressed in the placenta and is among several genes in myometrial relaxation and contraction pathways that are either transcribed in the myometrial muscle cells or they act upon the myometrium to regulate contractions. And, you know, I recall that preterm uterine contractions is one of the strong immediate risks for placental abruption. So this study really encouraged us to continue to press on in doing what I think is absolutely necessary given the pathogenesis of some of these pregnancy complications, where the complication occurs, or the genesis of the pathophysiology of the complications occur at the maternal fetal interface. And so continuing to look for maternal fetal genomic interactions, as well as imprinting a parent of origin as a way to understand these, the genetic underpinning of some of these conditions would be important. These are the kinds of studies that require very large sample sizes, and so will require thoughtful, careful, and well-aligned collaborations that would allow for hypothesis testing and then replication. And also, you know, we're just looking here at genetic interactions. I think there would be lots of opportunities to look at metabolomic and other multiomic characteristics at this maternal fetal interface as well. Just briefly, I wanted to share with you that the studies that I just described couldn't have been done without the engagement of a large number of different institutions collaborating, and very dedicated and wonderful collaborators and trainees. The architects of the study design that I described, the case crossover, was really developed and optimized by Malcolm McClure and Murray Middleman. And they developed the study design in 1991-ish, and really have brought forward a way of really asking and answering the question, why now? Why does this acute event happen at the time that it does? And I think it really gives us some insight into pathophysiology, and maybe even help us understand how to encourage populations to mitigate their risks. We had a number of methodologists help us justify the application of the study design in a complex clinical setting like perinatal medicine, and just lots of disciplines and individuals represented here. Studies are funded by the National Institutes of Health. And then finally, none of this would be possible going through, you can imagine, over 60,000 deliveries over 2+ years to identify round the clock, right, 24/7 recruitment and characterization of women with abruption. Required a large team of people dedicated to the research mission. And so I put some photos here of them, and I register my thanks to them, and thanks to you for your time and attention.
Thank you so much, Dr. Williams. And I see some hand applause in the chat, where I appreciate your body of work. We did have one question pop up, and if you have others, please feel free to either raise your hand or put it in chat. And so from Dr. Gibbs, very nice presentation. When in gestation did most of the placenta abruptions occur, and what were the perinatal outcomes?
Yeah, that's a great question.
Michelle, if I could just expand that, I'd like to know whether this mechanism that seems very interesting might apply to early placental abruption as well as placental abruption later in pregnancy.
Yeah, so that's a really good question. All of these abruptions happened after 20 weeks because that's by definition, right? And more than 50% of them happened before term. So more than 50% of them happened before 36 weeks gestation. If your question, Ron, is could this be used to study miscarriage, because that would be what would be categorized before 20 weeks, I would think that would be harder to do because it's not going to present for most of the cases as acutely.
Yeah, I realize early could be interpreted various ways. I was thinking, just as you got onto it, between term and preterm, abruption. So it's nice that you have that distribution, and might be interesting to take a look at that.
Yeah, that's a great idea. By the way, Ron, we did, while we were waiting for an abruption case to occur, there was probably 3 to 4 preterm births, early preterm births that occurred. And so as a side hustle, if you will, even though we weren't funded to collect cases of of early preterm births, we did. The team worked twice as hard to get those extra case group, and we were able to show similar associations where extreme physical exertion an hour before spontaneous preterm labor, resulting in a preterm birth, uncomplicated by abruption, is also found as a result of that acute exposure.
Wow, so this really has tremendous implications for recommendations about exercise in pregnancy.
Yes, yes. And you know, the way I think about it is, given that the acute effect of heavy exertion is attenuated in women who are most fit, I think the message, the implications are entering pregnancy with a level of fitness is a good thing, and maintaining that fitness with moderate leisure time physical activity, we know from other studies, would be important. But for those women who are not physically fit and they are pregnant, the advice could be to do everything to avoid extreme physical exertion. It wouldn't be different than the advice we give to middle-aged men who live the life of a couch potato and then they go out and try to shovel snow, right? That would be the non-pregnancy counterpart of this observation, that you see acute increases of MIs during snow periods when, you know, dads get out there and they're shoveling snow when it's the first time they've been physically active for months.
Hmm.
Well, I remember seeing on CNN once, on an early Monday morning, it said the most likely time to have an MI was stopping exercise on Monday morning. So my conclusion was, don't stop exercising.
That's right.
I know we're a little over time, but I see the 2 hands up. Dr. Stevenson?
Hi, Michelle. I know we have a time to talk later, so we can talk more about this in some detail. I was going to ask you the question about, you know, with a longitudinal cohort like that, the opportunity to actually see preterm birth, but as well, which you've told me, we can talk more about that later.
Yeah.
But I'm intrigued with the similarities that you described as you were sort of setting the stage for this study between the changes that we see in preeclampsia and abruption. At least in the chronic form, not the one associated with an accident or something of that sort. But we've recently just completed a large study. Virginia's been a part of it. It's called the EPIC study, where we're looking for signatures that would suggest that there's something that's different about some of the women with preeclampsia that leads to later cardiovascular disease. And so your observation about this increased risk in this group as well, again, brings me to the point that there must be similarities in the pathogenesis of these conditions. Yeah. And again, you reported the overlap here also in terms of the influence on what exertion might do to you if you, in fact, have preeclampsia as well at the time this is occurring. So I just wanted to hear you comment further about that. And the other thing I just thought about when you're talking about the PPAR is that upregulates the heme oxygenase system, and there are also genetic variations in how people express heme oxygenase, and we know that there are animal models that look a lot like preeclampsia if they're heme oxygenase deficient. So I'm wondering whether this enzymatic system might also be involved in the pathogenesis of these problems where people cannot mount responses to oxidative stresses that occur. So it's a couple things to think about, but maybe you could comment further on the preeclampsia and abruption relationship.
Yeah, you know, I think preeclampsia and abruption have always fascinated me, because especially around the chronic pathways, because it really starts with placentation. And I think the evidence accumulates to the point where you see a pregnancy progressing towards the risk of both of these conditions. And I don't know what or how one ends on the pathway towards an abruption or abruption and preeclampsia at the same time. I think, I was talking with Virginia yesterday, and I share her view that when we think about preeclampsia in particular, it's not one condition.
Mm.
And it might be that if we were to segregate out preeclampsia with abruption, it tells us something about the shared pathophysiology of both of these conditions that really don't distinguish them other than this abrupt delivery. And then it might tell us that there are acute abruptions that have absolutely nothing to do with the hypertension as a background risk factor.
Yeah, I agree. We work closely with Virginia, and she's convincing us as well that we're dealing with multiple tributaries leading into perhaps a final common pathway that we see clinically, but different causation early on.
Yeah.
Virginia, I see your hand up, so I might as well let you speak.
I was about to say, that'd be a perfect segue, Dr. Wayne, if you can ask your question.
Yeah. Very good. Yeah, actually, Michelle, this is great because I always have thought about abruption is a complication of preeclampsia, not thinking about it as a synergistic or an independent pathway. So you definitely have gotten me to have something to think more about. I actually just had a very technical question.
Mm-hmm.
For the limitation of the study in terms of recall bias, how long from the event were people needing to recall?
Yeah, good question. I think somewhere in the paper we list the interval between the time they're in the hospital and deliver and the time we get to them. I think it's a matter of it's a matter of 1 to 3 hours.
Oh, okay.
Okay.
So these weren't. This was
during
all
the
in
hospital.
real time. Okay.
Yeah, it's during hospital, but
Okay.
the recall bias is not so much that they may forget. It's that they've just gone through this event and they're thinking hard about what they've done. Now, we didn't tell them what triggers we were going to study, so we just asked a whole slew of questions. But I think the challenge here is a more pristine way to do this would be to get an objective measure. So, for example, if we had wearables and we could show heart rate spikes, concurrent with the report, then we could be more confident that some of this effect that we're seeing isn't influenced by the hyper reflection of what happened right before this traumatic event.
Michelle, just we can talk more about this too. We just finished a study with Sarah England at Washington University, St. Louis, looking at sleep, and we used wearables for that purpose. Yeah. We're able to associate differences in exercise and sleep with basically preterm birth.
Yeah.
So I think this is a really wonderful tool that you could apply here and get much more precise understanding of the relationship between exertion and these events. Yeah,
that's great. I think wearables is the way to go. The challenge is to be sure that enough women have access to them. Yeah. Either on their own or through a sponsored study that provides the wearables to them.
Well, thank you so much. I think I echo a lot of the scores, the questions, and in the chat, Pinelli, actually, who's doing some research on wearables, really echoed kind of understanding that burst of activity. So I hope that there's some collaboration that can come out of this because we can kind of take this further. So thank you everybody for staying a little bit longer. We appreciate you as we go into the summer. I know we get a break in talks before we come back, but I think that's it from our end. And so thank you. Have a great summer.
Thanks,
Thank
Michelle. I
you.
made a good decision about where
Thanks,
to be.
Michelle.
Take
later.
care. Thanks, everyone.